in here.
That's okay. Can you pick up on the mic?
That's only for the video.
Oh, that's only for the video.
That won't work for people hearing.
I don't have any videos.
That guy right there.
So, I see. Okay.
For that, okay?
You mean for the recording? Okay.
Yes, I'm sorry.
Good. Well, thank you very much for coming. Our goal here today is to have a better understanding of Parkinson's, and I'd like to talk about one of the things I think it's extraordinarily important, and that is what is the actual cause of Parkinson's. Because at the present time, we do not have any neuroprotective therapeutic format. We have symptomatic improvement with drugs, but it does a very good job with that. But at the present time, we do not have an opportunity to go ahead and try to delay the progression of the disease, except for, I think, as the doctor talked about, and that's exercise. And I've been a big believer in that for a long time, and I think exercise is really very, very important. I personally believe there's a lot of evidence that exercise increases the trophic factors and helps nurture these dysfunctional cells, and also has an opportunity to give a greater chance of reducing the cell dysfunction as it starts. So we're getting our slides up. So what I'd like to talk to you about in summary today is, number one is etiology. And I'm going to carry mainly the concept of protein deposition, because I think that's where it's headed, and that's where people like Warren Alano is really emphasizing their aspects of treatment, that the protein acts either as a substance that can be transmitted from one cell to another, or some way it becomes templated in the cell. And I'm going to talk to you about some very, very new, brand new information in ALS. Now remember, neurodegenerative diseases are Parkinson's syndromes, they're Alzheimer's disease, and Lewy body disease. And then probably, for most of us, we think that MS is another neurodegenerative disease. So we're going to talk about the etiology. The second is, we're going to talk about the concept of Parkinson's. And I might as well hit that. Oh, there we go. Parkinson's, how you make the diagnosis. Now, it's important at the present time, despite what other people say. We had a visiting lecturer here from Chicago last week at UCSD I went to. They said, well, you know, talking about Parkinson's and atypical Parkinson's is really the concept of what you tell to medical students. Now that's really not true. We think of idiopathic Parkinson's disease because it's got a very, very characteristic clinical picture, because we have no markers. We have no markers at all. But it has a clinical picture that's very characteristic, and if you follow that clinical picture to autopsy, you'll be right 98.6% of the time. Is this cutting out? Okay. Hopefully we can avoid that. So that's important, differentiating idiopathic Parkinson's from atypical Parkinson's. And I'm going to briefly mention a little bit about atypical Parkinson's. And then we're going to talk about this important thing called etiology, because really this is where the key is. This is where the key is very key to asking how we are going to get an opportunity to change this phenomenon from symptomatic treatment to just getting something where it will stop the break of the progression of the disease. And I will have to finger point here when we get the change in the slide. So here's a little bit of the concept of what we're going to talk about, and I've already covered this, the clinical features, and I'm going to emphasize the protein aspect, and then I'll briefly mention some therapeutic issues. Next slide. So one of the things that's extraordinarily important is to understand that neurodegenerative disease has some very key important aspects. Number one, genes, these genes encode proteins. They make proteins. Now, how many people here have heard about Craig Venter? He's here in La Jolla. He's going to do 40,000 patients. He's going to do their genome, 40,000 patients. I'm not going to ask him to do mine. I'd be a little worried what I'd find. But genes is important. Encodes of proteins. And there's been an explosion in the number of genes that we've actually now known are involved. It's absolutely amazing. So when I was practicing and seeing Parkinson patients at Iowa in 68 and 69, we had no concept about genetic aspects. Now we've got 16 or more. And most diseases have what we call heterogeneity, or they have a spectrum. Their disease is a spectrum. Now you wonder, is that just the case for neurodegenerative disease? Well, it's not. Look at hypothyroidism. Look at pernicious anemia. All of these diseases have a significant heterogeneity, a clinical spectrum. And it occurs not only clinically, but anatomically and pathologically. That's why if you do an autopsy on a patient that has Alzheimer's disease today, they clinically have it, about 30 to 40% of them, when you do the autopsy, they'll have mixed pathology. And I heard the doctor talk about that there was definitely mixed pathology in some of the cases that they are dealing with. So that's a very important aspect. Now here is a slide that summarizes much of what I'm going to talk about, but in a very simple way. Number one, we have apoptosis down here. That means cell death. That's apoptosis, cell death. And we have three areas here that are very important. We have what we call the double hit. The double hit is genes, and we've talked about that. And at the present time, we've probably got 10 to 15% of the patients. We have a genetic phenomenon. LRRK2 is one of the biggest ones, LRRK2, and that's right here, that has some ethnic issues where some people from certain areas like Northern Africa have a greater incidence of it, and they oftentimes will have it. I probably have 30 or 40 patients, have lots of Parkinson's, probably generally people who see me intermittently. I have probably almost 1,000 Parkinson patients. I have about 30 or 40 people that have LRRK2. Now, genes are important, and they also are important because we have the concept here of the alpha-synuclein, and that's the protein that's involved. So genes play a role, and then here is the environment. Now, the most important thing about environment that we know is the concept of pesticides and herbicides. Now, being an Iowa farm boy, I'm always a little nervous about that because I was around all those pesticides and that when I was working in the fields for years. But it does look like you have a higher incidence of Parkinson's if you're around these, and there is some definite evidence of that. Rotenone and other pesticides. Rural living, other fungicides. But some things don't. Now, I was one of the defense experts on Parkinson's for the class action lawsuit for welding. And it's never been shown that welding plays a role in the etiology of Parkinson's. Now, manganese in manganese miners definitely play a role, but it's not classical Parkinson's disease. So that is the concept, if I could have this slide back again, sorry. That's the concept that what those two areas bring in, environment and the genes, is that what we have they feed into this entity called pathogenesis, or the mechanisms. And that is protein aggregation. And that's what I'm going to talk about today, because most people believe that's it. That's the etiology, or the bulk of the etiology. Now, when we talk about the etiology, the most important thing is almost all Parkinson's have what we call comorbidity. They got hypertension, they got obesity, they got vascular disease, they may have some Alzheimer's disease, they have hypertension, other important aspects. So you want to reduce the comorbidity as best as you can. So protein aggregation is important. There's always been the concept of mitochondrial disease. I'm not going to get into that too much. Oxidative stress, you talk about that with everything. Heart, other aspects. Inflammatory disease certainly plays a role. There is a component of inflammation, like there is in arthritis and other aspects, in the concept of the etiology of Parkinson's. And that leads to apoptosis, and that's cell death. So these two feed into there. Now, the advances in neurodegenerative diseases, I mentioned already, is the genome-wide association. And we're going to have in 20, 30 years, for probably $300 or $400, you'll be able to go down and get your genome. The question is, what will it be and how much will you worry about it? But that is huge. And we're doing these snaps that you have an opportunity to determine. The gene data is massive. The problem is we also need to duplicate it. So you have some duplication. So genes encode proteins, we've talked about that, and the pathology that we've had in the recent years to be able to study the pathological specimen is massively improved. And of course we're now doing MRIs and DAT scanners and PET scanners, all the things the government hates to see us do that cost money, but it's given us an idea, definitely, about some of the aspects of Parkinson's disease. Now, I use a lot of DAT scanners. I try to be conservative in it, but I think they're very important to use, especially the differential between essential tremor and Parkinson's disease. It doesn't differentiate between atypical Parkinson's, like multisystem atrophy or PSP, and Parkinson's, but it does differentiate between essential tremor, vascular disease, and drug-induced. Now, alpha-synuclein really is the area that most of us are really considered. And Warren Alano and other people are doing a lot of research in this, but there's Elizabeth Lee, who is at one of the universities, and she has done some fabulous work, and I'll talk to you about that a little bit later. But these proteins aggregate, and it's alpha-synuclein, which we all have in our body, but for some reason there's a mechanism that gets those alpha-synuclein molecules to aggregate into fibrils and then into oligomers and other aspects, and it actually deposits it as a Lewy body. And I'll show you a picture. A Lewy body is the pathological marker of the aspect of Parkinson's disease. So we know it's toxic because you can do clinical trials and in animals and it looks toxic. We also know in tissue cultures it's toxic. So the idea is it transmitted in some way from one cell to another, or is it actually able to be templated, meaning it can be copied? Now, Alzheimer's disease is a cousin, and it's a cousin in the sense that it's a neurodegenerative disease. It's mainly is beta amyloid and tau. Now, Parkinson's is alpha-synuclein. The atypical Parkinson's have tau and some other types of deposits of protein. I'm trying not to move, but it's not my movement that's doing it.
I'm texting to see if I can get someone to come here and...
So we know Alzheimer's plays a very important role. Now, much of this talk is on some of my YouTubes, and it's in your handout. So we're looking at this aggregation of proteins and actually what happens and what makes a difference. So we know genes play an important role in Alzheimer's. Genes play an important role for beta amyloid, and that actually is keyed, and young people with Alzheimer's disease will actually get that excessive amount of amyloid. So Alzheimer's disease is something that a lot of people get. It starts out at 65, you have about 3 to 5% of people with Alzheimer's. We know it doubles every 5 years. We know that some people with Parkinson's will have a Alzheimer-like appearance in their clinical picture. And when they have this dementia, if it occurs early in the Parkinson patient, it's called Lewy body disease. If dementia occurs in the first year, it's called Lewy body disease. If it doesn't occur early and much later, it's called the dementia of associated. Now, Alzheimer's has lots of important characteristic features, memory loss, but it has some other things. And I'm not going to go into that because it's in those handouts. But in Parkinson's, it's actually this concept of the alpha-synuclein. And we emphasize the concept of templating versus transmission. And I got some good slides to go over that with you. The Lewy body, as I mentioned, is the pathology that you see on autopsy, and that makes the diagnosis. The incidence in Parkinson's is very interesting. As you get older, it's about 1 in 100. 1 in 100. Age is the greatest risk factor. Genetics play a role. As I mentioned, comorbidity. That's why when Parkinson patients get their disease, I say slim and trim, avoid diabetes. If you have diabetes, do the best you can to exercise, good diet, and do everything else that's very important. So genetics, as we talked about, there are 16 genes. The clinical triad, you all need to know, and if anybody comes up to you and say, I have Parkinson's disease, what you want to know is you have a resting tremor, you have rigidity, that's stiffness, and you have akinesia, which is slowness. And if you have those three, then you have a great opportunity to, if you have asymmetry, to have the correct diagnosis. Early, you'll be correct in 75% of the time. If they're L-DOPA responsive, then they have a great opportunity at the end to be correct. So I look in L-DOPA responsiveness, I look at, they get a kick when they take the drug, they have wearing off before the next dose, and they get dyskinesias. Almost always those are patients of idiopathic Parkinson's. We have drugs we talked about, MAO type B inhibitors like rasagiline or Aricept. We have dopamine agonists, ropinirole or Requip. We have Maripex or Pramipexole, and those are all important. Plus we have L-DOPA, and hopefully we're going to get Ritari, because Ritari should really change the picture here of the disease. So, other atypical Parkinson's. Now, I'm not trying to make you an expert in this, but how many people here have been told, have been told, I may just be better to shout it out. How many people here have been told that I think you have Parkinson's disease, but I'm not sure? How many people have ever been told that? I think I have Parkinson's, but I'm not sure. Well, atypical Parkinson's is a very common phenomenon. It actually makes up about 10 to 20% of the patients that have significant Parkinsonism. And the group is progressive supranuclear palsy, which is PSP, and in the last 5 years we've expanded that out enormously. Multisystem atrophy, MSA, corticobasal degeneration syndrome, we've talked about syndrome here lately, and Lewy body dementia, which I told you about, and frontal temporal dementia. It's this entity called frontal temporal dementia that has really gotten a lot more interest and a lot more pathological evidence, because it's a disease that presents with memory, personality changes, cognitive behavior, and then develops Parkinsonism, a Lou Gehrig's-like picture, and other interesting aspects. The most important thing is we're just getting a picture of what it's like. But it's very nice to know, but we don't have a treatment for frontal temporal dementia, multisystem atrophy, or PSP, except for the few people that respond a little bit to L-DOPA. And some of them will. Some of them will respond to L-DOPA. So what's PSP? Well, this is a lot of important information here, but it's in your handout. And so basically, PSP, progressive supranuclear palsy, if you start to fall and have trouble with your gait early, get into a wheelchair fairly early, chances are you have PSP or multisystem atrophy. It starts in younger patients, and it is probably the second most common cause and it's got some genetic features, but it's stiff, rigid, and later on, the eyes don't move. And that's one of the aspects of PSP. Now, very importantly now, there's a lot of subtypes, and I'm not going to go into those, but we've got a better understanding. And we think of them as the PSP-P, meaning Parkinson's, and a lot of those people will actually have like Parkinson's early on, and they'll respond to L-DOPA. And mostly later, they'll have this difficulty with moving their eyes, and they'll have trouble with kind of a speech problem. Next slide. The next one is MSA, multisystem atrophy. Kind of presents like the same thing. And the phenomenon of that is they have a lot of autonomic phenomenon. They can't get their blood pressure regulated. It's very low. It drops when they stand up. They have trouble with bladder. They have trouble with erections. And they have a lot of autonomic dysfunction. And they can have stiffness, rigidity, and it's kind of an interesting entity. It's about 5% of my population. And then this slide is in a little more detail, because what we do is we divide it into cerebellar and Parkinson features. Next slide. Now, a new entity that we think about more is called corticobasal degeneration syndrome. And that's an interesting syndrome because it looks sometimes like a stroke. And then you have cognitive features, and some of those patients respond to L-DOPA, but not many. They may look early like people with Alzheimer's disease. And so the doctor is important to tune into that, so it sometimes will be a benefit. Next slide. And then this is the frontal temporal dementia. I know you're not trying to be neurologists, but I like to tell frontal temporal dementia this way.
We can't hear back here.
You can't hear?
There you go.
How's this?
Yes.
Sorry. Is it going to cut in and out?
Hopefully not.
Okay. Frontal temporal dementia, I always tell people, it presents like some of our politicians.
There we go.
Okay? It presents like a politician. They have abnormal behavior. They do all sorts of crazy things. And they have personality changes. And then later on, they look like they're a little frozen and stiff. And they get dementia. So that's what I think that's easy to talk about with frontal temporal dementia. It's got a genetic feature to it. We have a new gene that's kind of important. But right now, that's not as common as Parkinson's disease. Next slide. Next one. So we look at this entity now in subgroups, and that's kind of important because it's interesting for the neurologist, but it's also interesting in all the atypical Parkinson patients is that these patients have a shorter lifespan. They start earlier, they don't live as long, maybe 8, 10, 12 years, and then as compared to Parkinson's, you can tell a patient they live up to maybe 20, 25 years. Next slide. Vascular dementia is a comorbidity, and that's why when people get Parkinson's, you want to say, okay, be very aggressive about treating your hypertension, lose weight, exercise like crazy, and if you got diabetes, be very close and tight in your treatment of your diabetes. So vascular dementia and vascular Parkinson's certainly plays a role, and in most pathology, you'll see it's about 20 to 40% on the pathological examination of a Parkinson patient. Next slide. Lewy body dementia. I'm just mentioning this, and now after I get through these, I'm going to talk more about the etiology, but I just wanted to cover this. Lewy body dementia is somebody who looks like they have Parkinson's, but they get a cognitive impairment, dementia, within the first year. And that's how we separate it out. And I'll show you on a graph how that Lewy body pathology actually changes in a different way. Next slide. Now, how many people here have heard of mad cow disease? Okay, mad cow disease is a prion disease. And in the early times, when there was the outbreaks of mad cow disease, I used to go to England and give some talks and participate in doing studies and things like that for Parkinson's. And I'd always remember I'd have some beef, cattle. And then came the concept that the cattle got this prion, which is a small protein, from the sheep that was ground up, including their brains and their peripheral nerves, and was fed to the cattle, and the cattle got the disease called prion disease, what we call mad cow disease. And it's one of these spectrums of the entity called Jacob-Creutzfeldt's disease. Now, Jacob-Creutzfeldt's disease, or Creutzfeldt-Jakob disease, is a very important thing, and it's going to be very, very much more important as we find what we think is causing Parkinson's disease. So I'm through all that difficult, atypical Parkinson aspect. The mic sounds like it's working better, which was not causing me anxiety, but gave me a little bit of stress. And we're going to talk about this disease process that is very important with Parkinson's now. It's a disease in which has several categories, but you've all heard about mad cow disease. People would eat the food from the cattle, probably had some nerve material in it, and the person would get a disease that was rapidly progressive, and it would act like mad cow disease. And they would get cognitive impairment, they get the staggers, they get some Parkinson features, and they were usually dead in a year. Now, there is a genetic form of the prion disease. Prion means protein that can be transmitted in some way from one cell to another. Okay? And there is a genetic form, but the most important thing is right now, the incidence of mad cow disease, or what we would call really Jacob-Creutzfeldt's disease, is very uncommon. 1 in 1.5 million. Now, about 8 years ago, about 8 to 10 years ago, we had, at Scripps, we had Stanley Prusiner, who got the Nobel Prize for understanding prion disease and Creutzfeldt-Jakob disease. And what it found out was this prion could be transformed from one cell to another. And I'll show you some slides. So there is the sporadic form, which is the most common. There's the familiar form, which is due to a genetic predisposition. So what's the significance of this? Genetics and a gene on your chromosome, on your genome, can somehow key in a protein that you inherit that can cause this disease. And then there's a transmitted type that we know that occurs. Like if you got growth hormone from people who had pituitaries and you took it, and that patient had Creutzfeldt-Jakob disease, you'd die of Jacob-Creutzfeldt's disease, the transmitted type. Okay, so this is a protein. You can check the protein in the CSF. It's not 100% specific, but the important aspect is what we're really interested in is there an analogy between Creutzfeldt-Jakob of any of its type and Parkinson's disease, and that's where it's looking. And I've summarized that in many of my handouts and in those YouTubes. So now we're going to understand Parkinson's. We talked about the triad: resting tremor, rigidity, akinesia, asymmetry. You're right 75% of the time early, but if they maintain asymmetry, respond to L-dopa net, you're going to have the right diagnosis. And now we've understood about 3 phases of Parkinson's. And this is key because of the concept of genes. So the first phase of the 3 phases of Parkinson's, and this is in your handout, is the preclinical phase. Now that means you can't do a test on them now. You can't look at them and know they got Parkinson's disease. you have to get some kind of maybe genetic or other marker that we don't have yet to find that pre-clinical phase. Now, pre-motor phase we know all about. Pre-motor, loss of smell, constipation, depression, REM behavior disorder, things like that anticipate Parkinson's disease. 85% of the people with Parkinson's have lost their smell before they develop Parkinson features, and that's called the premotor phase. And then loss of smell, very important. That's the key. Next slide. So the three phases here are well documented. I've documented in that handout: preclinical, premotor, and motor. We talked about the motor. Next slide. Now the clinical diagnosis I've already gone over. That's the 75% you know right if you adhere to the clinical people. Next slide. Next slide. Now this is a DAT scan. Now DAT scan may play a role here in preclinical diagnosis. And at Scripps we do the DAT scanner. I think we're one of the only places around. And this is normal. And what it tells you is in the place where the dopamine is transmitted at the presynaptic area where dopamine is, and it goes across the synaptic cleft to the next neuron, there is a loss of dopamine. So when you have Parkinson's, you have a loss of dopaminergic function, loss of dopamine. This is what it looks like when it's normal. And as you get the disease, you have loss of uptake, and there's asymmetry, significant asymmetry. And that helps you with the diagnosis, but it doesn't differentiate atypical from idiopathic. Now the preclinical phase is important. Next slide. And I'm going to go ahead and emphasize that we've talked about that pretty much. But pathologically, this is the Lewy body. Now, I'm a hunter, so I always think of this as a bullseye. This is the alpha-synuclein here, and it's pathological for the diagnosis of the patient with either Lewy body or Parkinson's, depending on how they look clinically, but it can be seen in people who don't have the disease. Next slide. And that's alpha-synuclein. But here is what really became important. And this was the Braak classification. And I'm trying to tie all this in here with you. This is a slide that Dr. Braak and his wife worked together. And on the vertical here is the anatomical location of where they looked at pathologically. And down here you can see it's the olfactory nucleus and the vagus. Then it's part of the brainstem here. This is the substantia nigra, where most of the dopaminergic loss is. And then these are areas of what we call pre-symptomatic and symptomatic, and this is time. And they monitored all these Lewy bodies, and they found out they had a very consistent geographic and time sequence that was important. Now, why is that important? Because it plays into the concept of the prion, or the transmission of the alpha-synuclein, as the way the etiology comes about. So it starts down here, spreads up the brain, and then goes up here into the cortex. So down in here, the patient isn't symptomatic. Next slide. So the pathology I've already talked to you about. It's aggregated alpha-synuclein. It starts as alpha-synuclein, it aggregates, and then you go into these other aspects. Next slide. But the important thing is, that's how the Lewy body is formed. The alpha-synuclein aggregates, and then it's kind of dumped into this area in the cytoplasm, and it looks like that bullseye, and it's what you look at pathologically. So this aggregation is the key. Now, when you give a talk, you mention something at least 3 to 5 times so you can remember it, and that's why I brought this up. But that also occurs in prion disease. It occurs also in Alzheimer's disease, and it looks like it occurs in ALS. And it's keyed by environment and genetics. So this alpha-synuclein aggregate is a toxic phenomenon. It's toxic. And what we mean by template, it's kind of like a template is that if you put a little particle of it into, say, a dish of something, and the particle is a spit, and you look at it and say it's a soup and somebody spit in the soup, you'd see it. And then that bacteria spreads throughout the whole soup later. So that's kind of like templating. Or it is transmitted in some way. And that is the concept that we're really talking about. Aggregation, templating, or transmitting. So this is red hot off the press. And this was done at Columbia. You haven't read about this in the newspapers probably. I know the individuals who are doing this. There are 2 centers that are very key into doing this. And this is on Lou Gehrig's disease, or ALS. Now, what's the significance of this? The significance is that you can look at things in animal models, like was shown in exercise, and then you have to look at in a tissue culture, either before or after, and then you have to know what goes on in humans. But in ALS, they found out that taking human cells from patients with ALS, Lou Gehrig's disease, they took those human cells and they used those cells from people with ALS and they put them in a cell culture in vitro of normal cells that have never had any contact. We call them embryonic stem cells. And this has some ramification as to stem cell implants. They put them in there, and guess what happened? Those embryonic motor neuron stem cells had a process that showed that they got abnormal, dysfunctional, and they had cell death. The cells died. So you get the significance. Just by geographical relationship in some way, the cell that was from the patient that had ALS contaminated in some way that cell that had no exposure. So in some way it was transmitted in some way. So I'm not going to go into all that, but the question is, what is delivering that message? Is it a message system? Is it biochemical? Is it protein? Or what is it? It looks like in the ALS group, it's a supportive cell that occurs in the brain called the astrocyte. And that's kind of the cell that makes the scars in that. So this is very important. Now, there's another person that's doing this in Parkinson's, and I'll bet she ends up with the Nobel Prize. Next slide. And that is Elizabeth Lee, a little tiny lady. She spent her whole life doing this, and she's brighter than heck. At the Montreal meeting that I gave some papers at in last fall, she presented a lot of her important data. And in a nutshell, here was her data. She could take a Parkinson patient's dopamine cell or neuron that was affected with Lewy bodies, and she could put it in a cell culture that had these cells with their not contaminated, and in a few days to weeks, that cell that was from the Parkinson patient in some way developed Lewy bodies in the other cell. So the obvious phenomenon of concern is, what in the heck is going on? What in the heck is going on that allows that? And I'll show you what we think it is. Next slide. So here's the story, and I'm ending this way. It is the potential mechanism for transcellular propagation, meaning promoting, of the protein that's misfolded. Now I'm going to show you how this and why it's important. So you have local spread of this in some way, say in the cell. Next slide. Okay, this cell that's contaminated comes over here and sends some message to this other cell, and it's cell death. But these cells here that are dead have a protein in it that still may have some ability to become toxic. Next cell. And then that toxic protein aggregates and is taken up or has some kind of ability to get into that cell, and that causes that cell to die. Now, what's the importance of this? Well, you got to find out that mechanism. And the other important thing is you may be able to pour a lot of cells into somebody's brain with Parkinson's, but if this mechanism is correct, which most people think it is what's going to happen to those cells that you put in? They're going to die. And that's what happened when we looked at the pathology, when Warren Alano and Cordover looked at the pathology of people who had embryonic stem cells that were implanted. When they died, all their stems, not all, but many of their stem cells had Lewy bodies. Now, next slide. So now, what's the mechanism? Well, you can look at it this way. It's called exoptosis. So the exoptosis takes place. This abnormal toxic something, alpha-synuclein here, extrudes this, releases it. Next slide. And it's taken up by this other cell. There's some mechanism. Spits it out, the other cell takes it in. There's some mechanism. Next slide. And that aggregated phenomenon occurs. Now the other possible, and Stan Prusner has thought that this is the case for prion disease. You have here a network of cells, and say this is, sorry some of you can't see it, this is the neuron in the substantia nigra that produces dopamine. It gets Lewy bodies in it. It transports the alpha-synuclein up to here, then it releases it into the synaptic cleft, and then the other neuron, the postsynaptic neuron, takes it up. So obviously, we have to look at this in a new and different light. Next slide. So here's how we're going to think about it therapeutically. And this is pretty much the gist of what I've been talking about. Aggregation, transmission, aggregation, and then transmission or templating. So you have a cell that can release this abnormal toxic something, or this aggregate. So initially what you could do is you could block that release. Now we know we have particles or drugs that can block the release of substances, neurotransmitters from cells, because we do it all the time in hypertension and in cardiac aspects. So you block the release, or that toxic aggregate is around there swimming somewhere in the synaptic area, and you get some type of agent like the astrocyte or the microglia, and you signal it and you say, okay, I want you to attack that aggregate, and you genetically key it so it can. Guess what happens? You clear that, and it doesn't go to the other cell. So you block the progression of the disease. You essentially have a neuroprotective agent. Now, then you could get an antibody, and you could give the antibody and immunize the patient. And if you immunize the patient, then that would go away. Well, we all know we got antibodies. That's how you get pernicious anemia, you get some thyroid disease, other aspects. The problem is, in Alzheimer's disease, they did the clinical trials with antibodies, and it, number one, didn't work very well, and number two, people got an encephalitis and they had to stop the study. Now, also, using a drug like IVIG hasn't worked very well in Alzheimer's. So then the next thing is that you can block right here, block the uptake. And then you block the uptake, and if that doesn't work, you can increase the degradation or the breakdown of that abnormal toxic substance in the cell. Now we've done some work with that. Warren Alano's done some work with that using the proteasome system, and it actually hasn't worked so well. Next slide. So I mentioned this IVIG, which you may or may not know. You use it in MS, myasthenia gravis. It hasn't worked in neurodegenerative disease. Next slide. Markers right now are not significant enough. They're looking at spinal fluid markers. It may be a benefit, but it's only beneficial diagnostically in about 85% of the case. What we need is an absolute 100% marker that will tell us if you got it or you don't have it. But the problem is it's a spectrum disease, and we probably have comorbidity, so we're not going to be able to pick it up. Next slide. The preclinical phase is really where we need to be. We need to have testing biomarkers where have a preclinical phase. We can make the diagnosis and get a drug that will actually do any of those things we talked about. So in summary, I've tried to cover for you, despite some of the difficulty with the mic we had there early, about the importance of knowing the diagnosis. That's the key, knowing the diagnosis. Number two, knowing the clinical triad. Knowing that there are other diseases out there that may not respond as well with L-DOPA, they may get a little response. It's important to make the diagnosis though, because cognitive impairment occurs earlier. And the other important aspect is lifespan might not be as long. And then I've covered the concept of how the disease can be treated, because we're talking about alpha-synuclein, which forms Lewy body disease, which is very important in the concept of templating and transmission. Now we're going to know a lot more about this. I think this data is going to actually escalate very quickly. So I appreciate your time. Sorry about the mic. I think we got it worked out there for a while. I'll be happy to answer any questions here afterwards, but I just want to tell you a little joke about these 4 people who were in a plane. And 4 people in the plane. There was a pilot, a minister, a Boy Scout, and a politician. And, you know, we're going through lots of political things today, but these guys were flying in the plane, and so suddenly the engine stopped. And so the pilot said, listen, he says, I've only got 3 parachutes. He said, I'm the pilot, I get the first one. He said, we got to bail out. He grabs the parachute, he jumps out. So the other passenger says, look, he says, I'm a politician. He says, I'm a politician from California. He says, I'm very smart. California can't do without me. I know more than anybody else. He grabs a pack, he puts it on, and he jumps out. So the minister looks at the Boy Scout, and he said, you know, you're an Eagle Scout. He said, you're young, you got your whole life. He said, you know, you used that last parachute. And the Eagle Scout looked at him, he says, don't worry about it. He said, you know that politician that's so smart and knows everything? He grabbed my Boy Scout pack and he jumped out. Okay, I'll be happy to answer any questions later. Thank you. Hello. Hello. Hi.